So coming to the septal rami, as said, this septal rami is a branch that is given out by the posterior interventricular branch, which passes through the substance of the interventricular septum and supplies posterior 1/3 of the interventricular septum. That is the septal rami. So here you can see this is the posterior interventricular branch, which is supplying the diaphragmatic surface of both right and left ventricles. And at the posterior interventricular groove, it gives a branch which passes through the interventricular septum, which is called a septal branch, which is supplying the posterior 1/3 of the ventricular septum. So this posterior interventricular artery also gives rise to a nodal branch, which takes a recurrent loop. So it passes backwards and supplies the AV node, that is atrioventricular node, which is present in the triangle of Koch, if you remember, is bound by tendon of Tedaro, the atrioventricular orifice of the right side, and the coronary orifice. So that forms the triangle of Koch, which lodges the AV node and is supplied by the nodal branch, which arises from the posterior interventricular artery and takes a recurrent course for its supply. So the SA node has its supply from the right coronary artery. AV node also is supplied by the right coronary artery. Now coming to the atrial rami. So these are the atrial rami, you can see. So these atrial rami, they supply the posterior surface of the right and also a part of the left atrium nearer to the interatrial septum. So coming to the left coronary artery. So this left coronary artery is wider than the right coronary artery and supplies the larger volume of the heart, that is the myocardium. And it arises from the left posterior aortic sinus of the ascending aorta. The left coronary artery is a very short vessel. So it appears behind the pulmonary trunk, traverses towards the left, and is seen between the left auricle and the pulmonary trunk and divides into its terminal circumflex branch and the anterior interventricular artery. A thing to be remembered here is the left coronary artery, this one, does not give any branches. So the branches are given out by the circumflex branch and the anterior interventricular branch of the left coronary artery. This anterior interventricular artery is the continuation of the left coronary artery, descends down and towards the left within the anterior interventricular groove, and this winds round the inferior border of the heart at incisura cordis, which is a notch nearer to the apex, that is the incisura apicis cordis. At that part area, it winds round the inferior border and is seen on the diaphragmatic surface, that is the posterior surface, lodged in the posterior interventricular groove, which anastomoses with the posterior interventricular artery which is also lodged in the posterior interventricular groove, which is a branch of the right coronary artery. So this anastomosis between the anterior interventricular artery and the posterior interventricular artery happens at the junction of anterior 1/3 and posterior 2/3 of the posterior interventricular groove. Coming to the circumflex branch, the circumflex branch is lying in the left part of the atrioventricular groove. So this is the atrioventricular groove. So this is the right atrium, left, right ventricle and the left ventricle. So the left part of the anterior part of the atrioventricular groove, the circumflex branch lodges, and it winds round the left border of the heart and is seen lodged in the posterior part of the atrioventricular groove, anastomosis with the right coronary artery to the left side of the crux. So the crux is here. So to the left side of the crux. And a point to be noted is this circumflex branch is very much related to the mitral valve. So the mitral annulus is related to the circumflex branch. So there is all possibility of the circumflex branch being damaged during mitral valve replacement, which has to be borne in mind the relation of the circumflex branch to the mitral annulus. Now coming to the branches of the anterior interventricular artery. So the branches are the conus artery, septal rami, ventral rami, and the diagonal branch. You can remember by the mnemonic CVSD. C stands for conus artery, V stands for ventral rami, S stands for septal rami, and D stands for the diagonal branch. So let us see them in detail. So this ventral rami, that is the ventricular rami. So they are again 3 to 4 in number, the ventricular rami. This is the anterior interventricular artery. So there are about 3 to 4 ventricular rami, and they supply the right and left sides of the interventricular septum on the sternocostal surface. So it supplies both the right ventricle and the left ventricle. And these ventricular rami, they are oblique and they course downwards. Coming to the diagonal branch. So this diagonal branch is the left ventricular rami, the larger left ventricular rami, the first larger left ventricular rami, which arises from the anterior interventricular artery as the diagonal branch. At times, this diagonal branch may arise at the junction of the anterior interventricular artery with the circumflex artery. Then the left coronary artery is said to be trifurcating. Normally, the left coronary artery bifurcates into its terminal branches, the circumflex artery and the anterior interventricular artery. If the diagonal branch is arising at the junction of its termination of the left coronary artery, then the left coronary artery is said to be trifurcating into the circumflex branch, the diagonal branch, and the anterior interventricular artery as well. Coming to the conus artery. the right ventricular rami. The diagonal branch is the left ventricular rami, the larger left ventricular rami. The first larger left ventricular rami is the diagonal branch. Coming to the first right ventricular rami, which supplies the infundibulum of the left ventricle, is called as conus artery, which anastomoses with the right conus artery of the right coronary artery. They form an anastomotic ring around the infundibulum of the pulmonary trunk, which is called as annulus of Guyssens. Coming to the septal rami. These septal rami are given out from the anterior interventricular artery from both the anterior aspect, that is on the sternocostal surface, and also from the diaphragmatic surface of the anterior interventricular artery. These septal rami, they pierce the substance of the interventricular septum and anastomose with the septal rami of the right coronary artery, which are arising from the second segment of the right coronary artery. So here you can see the anterior interventricular artery, which is seen lodged in the anterior interventricular groove, like the posterior interventricular groove lodges the posterior interventricular artery. So this anterior interventricular artery, it supplies the sternocostal surface of both right and left ventricles to a certain extent, and then it gives a septal rami which passes through the interventricular septum, anastomosing with the septal rami, which is given out by the posterior interventricular artery, which is a branch of the right coronary artery. But the septal rami of the anterior interventricular artery, they supply the anterior 2/3 of the ventricular septum. So the anterior 2/3, the greater part of the ventricular septum, is supplied by the left coronary artery, and a smaller part of the ventricular septum is supplied by the right coronary artery. So these can have their origin also from the circumflex branch as a rare possibility. So this left marginal branch is also called as obtuse marginal artery, as it makes an obtuse angle from the circumflex branch, which is more than 90 degrees. And this left marginal branch is one of the coronary arteries which is more prone for the obstruction, the coronary block. And this circumflex branch has to be remembered for the factor that it is related to the mitral annulus. So any surgeries pertaining to mitral valve replacement can cause damage to this circumflex branch of the left coronary artery. So coming to the Kugel's artery. The Kugel's artery is the atrial branch of the circumflex artery, or the atrial rami, we can call it as. It's the atrial rami of the circumflex artery, which anastomoses with the atrial rami of the right coronary artery in the anterior aspect of the atrial wall, nearer to the interatrial septum. Here you can see this is what is the left atrium, this is what is the right atrium, Approximately this happens to be the interatrial septum. This is the ascending aorta. This is the infundibulum of the pulmonary trunk, which is called as conus. So this is the right coronary artery. This is the left coronary artery. So the left coronary artery divides into the anterior interventricular and the circumflex artery. So this circumflex artery, the atrial branch or the atrial rami, which is given out from the circumflex artery, is called as Kugel's artery, which anastomoses with the atrial branch or the atrial rami of the right coronary artery in the anterior aspect of the atrial wall nearer to the interatrial septum. This is one of the major anastomotic channel or the ring that is formed behind the ascending aorta. So it is called as retroaortic ring of anastomosis. Similarly, you can see here, this is the right conus artery, this is the left conus artery, which is anastomosing in front of the pulmonary trunk in the infundibulum area, forming the annulus of Vuissens, which is one of the preconal anastomotic ring. So these are the major anastomotic channels that are happening anatomically, and functionally they are impervious, as said. So is the reason all these coronary arteries and its branches are supposed to be the end arteries. And at a very minute divisions of these coronary arteries, at that level, there is a little bit of potential anastomosis that is happening between those branches. So this Kugel's artery also supplies SA node and AV node, few of the branches from the Kugel's artery. So when there is pacemaker placements, during that procedure, if the nodal arteries are injured, which should not happen, but if by chance they get injured, there can be the collateral circulation that can be established by these Kugel's arteries. They supply these SA node and AV node to a very, very minimal extent. Since this is the larger atrial rami, which is arising from the circumflex branch, it is also called as arteria anastomotica auricularis magna. So there are these main anastomoses, as we said. This is the annulus of Vuissens, which is formed at the infundibulum in front of the pulmonary trunk, this one. And there are these septal anastomoses also, which is one of the major anastomosis that is happening between the right and left coronary arteries within the interventricular septum. And this is another one, the atrial branches of right and left coronary arteries, which are anastomoting in the anterior wall of the atria, which are called as the Kugel's interatrial ring, which is happening behind the ascending aorta. So it is called as retroaortic ring as well. Here you can see a diagrammatic representation. This is the right atrium, this is the left atrium, pulmonary trunk and the ascending aorta, which is giving rise to the right and left coronary arteries. The left coronary artery, which is giving rise to its terminal branches, the circumflex and anterior interventricular artery. So this circumflex artery, which is giving the atrial rami or the atrial branch, the larger, longest one, and the right coronary artery, which gives the atrial rami, they anastomose in the anterior aspect of the atrial wall nearer to the interatrial septum. So this is all is about the Kugel's artery. So coming to the coronary dominance, the artery that supplies the posterior 1/3 of the interventricular septum, which is the posterior interventricular artery, or clinically it is called as posterior descending artery, that will determine the coronary dominance. So if posterior interventricular artery is a branch of right coronary artery, then the coronary circulation is classified as right dominance. If the posterior interventricular artery is a branch of circumflex artery, which in turn is a branch of left coronary artery, then that coronary circulation is classified as left dominance. In rare cases, in about 10% of the population, if the posterior descending artery or the posterior interventricular artery is formed by both the right coronary artery and the circumflex artery, then the coronary circulation is classified as a balanced type of circulation, which is called as codominant. So normally the coronary dominance is the right dominance. 20% are balanced, that is codominant, and 10% are left dominant. So these left dominant people are more affected by coronary diseases because, as we said, the left coronary artery supplies most of the myocardium of the heart. And the balanced type of people are least affected because they almost share the equal volume of the myocardium for their supply. So since this anterior interventricular branch of the left coronary artery, since it is of more caliber and has a longest course too, is more prone for the atherosclerosis and is found mostly in men. That is the reason this anterior interventricular artery is called as widowmaker. So coming to the peculiarities of coronary circulation, the coronary vessels are the only vessels where the blood flows during diastole, and these coronary arteries are end arteries. They are considered functionally as end arteries, but anatomically they are not end arteries because there is anastomosis that is happening between the branches of the coronary arteries. And these capillaries of the coronary arteries have very high density and have very high oxygen extraction as well, because they are arising from the ascending aorta where the oxygenated blood is just pumped to the systemic circulation. And the regulation is mainly by the metabolites, as the autonomic nervous system has negligible effect on the coronary function, because parasympathetic stimulation has negligible direct effect on coronary arteries, whereas the sympathetic supply has a bit of effect on these coronary vessels where the constrictor receptors are prominent in epicardial coronary vessels, whereas the dilator receptors are prominent in intramuscular arteries. So the sympathetic stimulation, it constricts the epicardial arteries and dilates the intramuscular arteries, which happens to have a promising effect during the coronary insufficiency and in vigorous exercises. So a bit on these anastomotic channels that are formed between the coronary arteries, and there are collateral channels that are formed between extracardiac arteries also, that is between the coronary arteries and the pericardiaco-phrenic arteries, which are very much related to the surface of the heart, like few of the bronchial arteries, few of the esophageal arteries. They are intercoronary anastomosis also. So in normal heart, there are no communications between the large coronary arteries. The communications happen between the smallest of the capillary branches, which are about 20 to 250 micrometers in the caliber. So the larger arteries have the anastomosis, and these arteries behave as end arteries because functionally they are considered as functional end arteries because the anastomosis is impervious. Whereas the anastomosis of the smallest branches of the capillaries does have a potential anastomosis. So the common areas of anastomosis, as we have seen earlier, are between the anterior interventricular artery and the posterior interventricular artery in the posterior part of the interventricular groove, and between the circumflex artery and the right coronary artery nearer to the crux in the posterior part of the atrioventricular groove, and between the septal branches of the right and left coronary arteries in the interventricular septum. So these extracardiac arteries, which form the collaterals, are of a bit of life-saving, where there is ischemia or the myocardial infarction that happens, that is compensated for a very minimal time by this external collaterals. And to define the coronary dominance, it is defined by the vessel which gives rise to the posterior interventricular artery, which supplies the myocardium of the inferior 1/3 of the interventricular septum. So about 75 to 80 or 85% are all right dominant, where the posterior interventricular artery is a branch from the right coronary artery. Here the right coronary is represented by the green color and the left coronary is represented by the red color. So this is the right coronary dominance, where most of the myocardial area, including the most part of the interventricular septum 2, is taken over by the right coronary artery. That is the posterior interventricular artery, which is arising from the right coronary artery. Then we say it as right dominance. If the posterior interventricular artery is the continuation of the circumflex artery, which in turn is a branch of the left coronary artery. Then that coronary circulation is defined as left coronary dominance, which is seen in about 15 to 17% of cases, wherein you can see most of the myocardium is having its supply by the left coronary artery. So in the balanced type, there is this left coronary artery and the right coronary artery, both are contributing for the posterior interventricular branches. So then there is equal distribution of the myocardium that is supplying by the right and left coronary arteries, which is called as the balanced type or the codominant type. So why do we have to know about this dominance is in myocardial ischemia or infarction or imaging of the coronary arteries or during invasive coronary angiography, for planning the bypass grafting. So what part of the myocardium is supplied by the right and left coronary arteries makes the important decision planner. So that depends on the dominance of the heart.